Well, I'm excited to introduce to you our next speaker, Dr. Shankar Kura. He is the Chief Medical Officer at Centera Health in Norfolk, Virginia. He's previously been the Chief Medical Officer at Alignment Health in Rapid City, South Dakota. Was there during the COVID outbreak, and also at Fisher Titus Medical Center in Norwalk, Ohio. He received his MBA from George Washington University in Washington, D.C., and did his residency in internal medicine at Indiana University. You have been around. He's board certified in internal medicine and has practiced emergency medicine, hospital medicine, as well as geriatric medicine. And I could tell as soon as he walked in the room, he's got a lot of, just a great spirit about him. So I know we're going to enjoy this next talk. So Dr. Kura, thank you so much. And there's some water here if you need.
Thank you, Jen. All right, hey, thanks for coming. Good morning, everyone. Happy Valentine's Day. Happy Venereal Diseases Day. And those of you celebrating Happy Ash Wednesday. But I also want to take a minute to say this is Black History Month. So I'm going to pay a little tribute to a very important person for medical field, especially biomedical research. The biomedical researchers call her the mother of medicine. Yeah, we're going to talk about, just briefly, her name is Henrietta Lacks. Most of you might have heard of the HeLa cell. That's, her first name and last name, first letters. So Henrietta Lacks died at the age of 31 in 1951 in Johns Hopkins, unfortunately from cancer. But what she gave to biomedical research is amazing. Her cells are the only, well, they were at the time, the only immortal human cell line. Every single biomedical breakthrough has been because of her cells. So the polio vaccine, every vaccine since, including COVID and the Mpox vaccine, smallpox vaccines, right from concept to development to testing, is thanks to her cells. What's more astonishing is pretty much every HIV drug, chemotherapy, pretty much all of it, and the Human Genome Project couldn't have been successful without the HeLa cells. By hybridizing and creating the first human-animal hybrid cell, they were able to then map the functional sections of the genome, which then led on to ENCODE and the project that led to human genome. What's even more astonishing is there's a Nobel Prize winner who used the HeLa cells to basically verify, validate, and prove that cervical cancer is caused by human papillomavirus, because that was the first identification of a cancer caused by an infectious agent. And that was because of the HeLa cells showing these HPV agent was in those cells, and he was able to then make the conclusion. So it's pretty cool. Just wanted to bring the fact, as we celebrate Black History Month, the mother of modern medicine in a lot of ways. All right, we'll get to my talk here. Okay, so I'm going to try and keep this brief. I have a lot of slides. Some of them, I just, I've always been interested in public health. I did my medical education in India. I did my internship here in Indiana, and I did my fellowship also here, but not in infectious disease. I'm an internist, board certified. I have geriatrics as my fellowship. I also worked as medical director for an accountable care organization. So to one of the questions that were asked earlier, that's a real challenge. We are figuring out that structural inequities, and they're not very homogeneous. You can just say just Black and Latino, but it's bigger than that. There's intersectional problems where you have all kinds of little factors coming in and you get a whole complex picture. So you're talking about not just race, ethnicity, sexual orientation, citizenship. You're talking about poverty, education. All these things intersect and create this inequity, and that's very deeply rooted in structures that we have antecedent to what is happening today. And Lauren pointed out COVID-19 is a great example that really exposed the worst of the worst. We knew this before COVID-19. We were talking about it all along, and then COVID-19 showed the structural inequities that really disproportionately killed and infected more of the racial and ethnic minorities than should have been in a country that has the resources. Okay, so my objectives, I'm going to a little bit of overlap here with Lauren's talk. Sorry for that, but I just feel like that'll just set the stage a little bit. Mpox outbreak and evolution, and then prevention and control strategies briefly, and then vaccination. That's where I'll try to focus the most. And then what strategies, especially with today being Venereal Disease Day, and how the STI clinics play a big role in that. All right, so that's our 5 chapters, if you will. So briefly, Mpox virus, the family is Poxviridae, and it's orthopox viruses. There are 5 that infect humans. There are 12 total, but only 5 that are human, and Mpox is one of them. And the other one that everyone knows is smallpox that has been eradicated. So first isolated in 1958 in Denmark by researchers. You can see a rhesus macaque here, but the monkey that they did was a cynomolgus monkey from Singapore that they brought to their lab for lab purposes. And then 60 days later, they developed these very characteristic lesions that they, for the first time, identified as a new type of pox virus under the orthopox viruses, similar to smallpox, but not smallpox, and definitely not chickenpox. That is totally unrelated, not this family whatsoever. And then the World Health Organization announced they would prefer the term Mpox than calling it monkeypox, because that has very bad connotations. The associations are historical, that people tend to, it's a slur on whole communities and regions of the world. And I know the bottom picture is the African dormouse, and several of the smaller, the Gambian rat and other small rodents are the reason, not the monkey. Monkey, just like the human being, happens to get it from these small rodents. We don't know the origin exactly, but we know these carry it. And the famous incident in the United States before this big outbreak in 22 was 2003 in the Midwestern states, where, in a pet shop in Texas that imported these squirrels and rats from Africa were housed together with prairie dogs that they were going to use as pets, which I don't understand, because I've been in South Dakota. They are not pets. They need to be left alone. There are lots of prairie dogs in South Dakota. No one has them as pets. So they just transmitted a prairie dog. The prairie dog was bought by a kid in Minnesota and bit him. And we had the first case, and then total of 47 cases in the US. So yeah. Okay, just a quick overview. This is the continent of Africa. So if you look at it loosely, Western Africa is the part that you see that is jutting out this way. And then Central Africa is the Democratic Republic of Congo and all those republics around it. So clade 1, the one with the higher case fatality rate of up to 10%, is mainly in the Central African republics and Congo and surrounding countries. Clade 2 is what we're seeing in the US, and in first case in the UK from Nigeria, and went over to UK, and then we had a transmission to the United States. Fortunately, it's less than 1% case fatality. It's actually 0.16%, anywhere in that range, depending on where you measure it. But Nigeria, Ivory Coast, Liberia, Sierra Leone, those are the main ones, but then they transmitted those inadvertently by travel. So zoonotic disease, in other words, it's mainly a transmission from wild animals to humans. And you can see the outbreaks. 1970 was the very first outbreak in a 9-month-old boy, and then we had 47 cases there. And then 96 to 97, we had another outbreak again in Congo, 500 cases, all clade 1. And then 2002, we saw clade 2A, which is what those from the prairie dog transmission to humans in the Midwest. And then 2018, Nigeria had about 122 cases, all clade 2A. And here we come to clade 2B, very different from clade 2A. And Lauren pointed out something different we saw in her slide that clearly showed the difference between the previous outbreaks and the current one. So this is ongoing, and it's not stopped. I think that's the important message. If there's one thing, we need to be vigilant. We had a case last week in Wake County, in North Carolina, 3 cases, and it just shows that we're not in, this is not an endemic area. This is not West Africa, so you shouldn't expect cases here. And if you're still seeing cases, that's one takeaway today, is that we have cases and they can happen again here. And it's just a lot of it is structural. We are having a hard time getting through to those folks from stigma, from all these other reasons. Some of it is societal, that makes it very hard for these folks to get the right information or get the right care, access to the right care. And just give you if you look at the lineage of this, the ancestral strain at the bottom, clade 1 in 1972, then clade 2, which branches off to A and B, and B is what we're seeing the transmission since April, and then since the public health emergency was declared in July, and then really stopped in May of last year. This is the spread. You can see the green arrow starting in Nigeria, going up to UK, then there's spread from Europe to Oceania, all the way to the United States and South America. And then within the United States, we have transmissions going north and south. This is just something that Lauren has covered, so I'll move on. Some of this is, we'll just skip these 2 slides, skip this one as well. All right. So you got a basic background between mine and Lauren's talk about where we are. This is a transmission that is not endemic, but unfortunately it's come here, and now it's people-to-people transmission. We have to stop this cycle, and prevention is important, treatment is important. Dr. Olifield will talk about that, but I'll just try and focus on vaccination and strategies. I'll start by giving a history of the vaccine development, because this is the Mpox vaccine is actually the smallpox vaccine. We didn't develop a new vaccine for Mpox, because it's very protective, as you'll see. Smallpox variolation is a technique that was practiced for centuries, actually millennia, a way to inoculate people with doses of disease, and then hope that that will create a natural immunity, which will then prevent them from getting the worst forms of the disease. So it's had variable success until the birth of modern immunology and vaccination history. So you can see here is a stamp from Turkey, and I'll tell you, there's a reason why I put that stamp there later on. You'll see why, but it's just showing the practice of variolation, which is practiced for millennia there. And you can see in 10,000 BCE, we think based on the molecular clock, that's how scientists decide how old is the disease. They can actually, based on the rate of mutation, there's a linear relationship between mutation and the changes over time. And the best guess based on the molecular clock is this emerged in humans 10,000 years ago. And then there's remains of the Pharaoh Ramses V in 1350 BCE, showing that he died of smallpox. And then in 20 BCE, you have variolation in Asia and Africa. They were practicing, people were wise enough to understand that. Not a very successful practice, because you're talking about taking the actual smallpox disease and trying to use that to treat, sometimes successful, sometimes not. And then insufflation of fried scabs, all good, but not really very safe as well. And then if you go to 1716 in West Africa, as you can imagine, where the smallpox, there was a slave, an enslaved person, Onesimus, who informed his cotton maker who was working for, and then they used it in an outbreak in Massachusetts. And then you come to Lady Mary Wortley Montagu, who is a noble woman from England, who on her visit to Turkey discovered this and insisted that her children get it, and other royalty in England started adopting the practice. But here's the real story, right? I mean, the birth of modern vaccination. This is much safer way of doing it. And of course, there's a lot, even then, as one of us pointed out, people spread myths about these things. When Jenner introduced the smallpox vaccine, this cartoonist shows there's cows growing out of everybody's parts, everywhere. And just saying, because he had tried this out by taking not smallpox, but cowpox, which is much safer. and purposefully inoculating, people that, in this case, an 8-year-old, and he found it successful. And months later, he basically started our road, the journey to the vaccines. Okay, so we eradicated smallpox as a result of advances in making safe vaccines. So declared in 1980. The last case was 1971 and 77 in Africa and Somalia. And the last death was not related to transmission in the open. It was more a lab-related death. In 1980, the World Health Organization declared it eradicated. And you can see, after 3,000 years of suffering and death, there hasn't been a recorded case of smallpox in a half century. That's where we need to get to with Mpox. And Mpox, the challenge we're facing is truly a structural issue, because if you didn't have the structural barriers, we would have people coming and saying, hey, I think I'll be at risk. Can I get the vaccine? And they'd be more receptive even to the scientific community coming out of the message saying, hey, we have a vaccine that is extraordinarily successful, 86% successful. A quick rundown of the different generations of vaccines. So just focus on this box here. First generation using a live virus. We used to have dry-vax and wet-vax, which were by 2 different labs. And the second generation, we used a live virus as well. ECAM 2000, and then Adventist Factor smallpox vaccine. And now we come to the third generation, which is what I'm going to focus on, because that's the one that across the United States we're using for this outbreak, and we'll probably use for a long time because it's very safe, as you'll see, and highly effective. That's the Jynneos vaccine, manufactured by Bavarian Nordic. It's live virus, but what's very different is it cannot replicate in the cell. And it's unsuccessful at forming competent viruses. So it'll form some parts of it, but not enough that it can release and infect the person. So this is very important takeaway as well. Not only is the vaccine safe, the vaccine will not cause the disease. Okay, the why. We want, obviously, it life-threatening. As you saw, 1% and then 10% if it's the other clade 1, which thankfully we haven't seen here, but that can happen. Immunocompromised population, HIV, there are cancer patients, all kinds of folks that can die. And vast majority of the deaths in the United States and abroad are for immunocompromised situations. We don't want a pandemic, obviously. Only less than 25% of the population is fully vaccinated with 2 doses. That is really sad. We should get there, or we wouldn't be seeing these cases week after week. Without vaccination, it will continue. We'll see that sporadic outbreaks. We have to protect our healthcare personnel at high risk, those at high risk for that. Pregnancy, we don't want to lose that. Neonatal Mpox, that's another thing. And then there's a high secondary rate of Mpox, rate of almost 10% in unvaccinated people. So that's not good. These third generation vaccines are extremely safe and extremely effective. And this is a modeling, just showing you what impact vaccines have. So if you just look at the very bright purple at the very bottom, vaccine and behavioral changes, you can see here how quickly that dissipates the disease. And if you go with no intervention, you have a massive peak and very slow climb down. So there's a lot of, under this curve, all these people are affected. That's not good. If you just did with behavioral adaptation, you can flatten the curve, but you're still having large people here suffering. There's a lot of morbidity there. Vaccination, if you look at just vaccination, yes, you can, but you need to combine with behavior. All right, so we'll focus now on vaccines for the next few minutes. 3 vaccines available, even though I say they're available, this is the one that we'll be really using in true availability. These are just available in case we run out of these in the unfortunate situation that we have a real major outbreak. We don't have that, so it's going to be Jynneos that I'll focus on. It's the preferred vaccine. And this is just for investigational drug use only and emergency use authorization. Okay, we come to number 3. Hopefully you're still with me. There's a lot to cover. I want to spend this third part to make sure we at least take home in the best, simplest way possible that we can translate to folks to say the vaccine is safe, and not only is it safe, it's highly effective. So the company that makes this is Bavarian Nordic, and it's called Imvamune, and it's actually the generic vaccine referred by different names. And it's co-developed with the U.S. government's BARDA, which is the agency that oversees, these kind of advanced research. And it's a live virus that has been incapable of weakened form, but incapable of replicating. And it's the third generation, 85% effective. So for those of you a little bit interested in this, slide might be interesting, but you don't have to remember any of this, but it's kind of a fun little journey to see why this vaccine is so safe and how long it took to develop such a safe vaccine. So let's start here. So in Turkey, I showed you that stamp. That's where this original strain for this vaccine that we developed, that was developed by Bavarian Nordic. In 1948, it was propagated on calves and donkeys in Ankara, Turkey. That's why it's called the vaccinia virus Ankara. And vaccinia is, as I told you, smallpox. It is used for smallpox. So vaccinia, we don't know the exact origin of this virus. Probably more related to the horse virus, because 90+% of it is similar to the horse virus. But anyway, this is the virus that was developed in this strain, propagating through these calves and donkeys to attenuate. The more you propagate this, successive generations become weaker and weaker. The strain is not pathogenic, but it's good to create a good immune response. And this was used in vaccination campaigns against smallpox. And it has this effect when put into the skin, it creates a local reaction and inflammation, a hardening. Almost looks like you gave someone that smallpox, but in fact, what it was a local immune response, and that was typical of these early generation vaccines. So then this was brought over to the University of Munich Institute for Infectious Diseases, again used in smallpox, and again had a similar effect. But what was different, they brought it here and cultivated on chicken eggs. So that's why it's called Coriolantois, which is describing the part of the egg. And you got the vaccinia virus Ankara. And then we move on further from 53 to 68. After 516 passages, now you have what's called a modified virus, even better version. In other words, it does not cause any of these effects that we're seeing on the skin. See, no effects. And the strain is so weakened, but it's very effective in creating a protective immune response. And then finally, we come to our version. This was in 1977. Further passages. This was used in a lot of Germans to vaccinate against smallpox, very successful, and it was approved. And this is the Jynneos vaccine, which is based on what's called a modified virus Ankara. Bavarian Nordic, that's the company name, 584 passages later. Okay, that's a dense slide, so we'll move to something less dense than that. So it's alive. It's very attenuated, as you saw, serial passages, 580 passages. It's not replicating. That's the most important thing. So it'll enter the cell, it'll express its genes, it'll duplicate its genome, but it cannot assemble infected particles. And these are not released from the cell. And this is another testament to how safe this vaccine is. The virus that's used, the modified vaccine Ankara, can be at level 1 condition, which is the lowest level, BSL. So that's another, just to give you an idea. And what's attractive about it is high safety profile, very immunogenic, so very good response, both for antibodies and the T cells, which are very important, 2 types of response, the B cell and the T cell. No adjuvants needed, so you don't need to boost its thing. It does its job. And it's not replicating. So it starts, like I explained here, but it does nothing, non-pathogenic. And this is the part, it has a lot of what we call payload in order to put into these viruses. So you can actually inform, you can use it as a vehicle to inform the human immune system to make antibodies properly. So it's a very, very good future for other vaccines as well. It does not persist. It's very virus-specific control in its expression, low production costs. Storage and transportation as well. So anyway, this is just, again, composition. People ask you questions, what's in it? Really, half a mil of it, it's just no less than 5 and 10 to the power 7 of these units of this very, very attenuated modified vaccinia onca. There's very traces. We're talking less than 1 parts per million, obviously, the chikungunya fibroblasts on which it was developed. A little bit of this one maintains the pH. We're talking about barely, you can't even sniff it out if you try it unless you did very special techniques to find it. Benzonase, this is to prevent this bacteria that degrades these kind of, and these are used to degrade the DNA, so you don't want to do that. And then these two, gentamicin, cipro. No adjuvants, no preservatives, just salt and water. And it can be stored 3 years, 5 years, 9 years. Okay, this is the monkey I was talking about, cynomolgus. This is from Singapore, actually. It's a picture taken by someone in Singapore. And this was the one that first started it all when we first isolated this virus in the monkey. And that's why the unfortunate name, we don't call that anymore. We call it Mpox now. Okay, so in September, it was approved. In August, they said, hey, we can allow use of for individuals younger than 18. 0.5 more doses, then an alternate regimen which uses only 0.1 dose. So now you maximize the number of vaccine available. And then probably more than this now, but 1.24 million doses have been given. And we know the safety profile as well from that. So again, important point to remember. Okay, sub-Q and ID dosing. Sub-Q is 0.5, 0.1 for the ID. You can also do 0.1 for that. Any age with a history of developing scars, which are very hypertrophic scars, and individuals less than 18 years of age should receive vaccine via the sub-Q route, because by doing intradermal, and it can cause these scars in these folks. Those are very few concerns. And then stigma or other personal reason, if people say they don't want to be given intradermally, then offer them sub-Q. CDC recommends that you have both sub-Q and intradermal options available for people on site, and you should discuss which route for each patient. Okay, so within 4 days of exposure, you want to give this vaccine. Between 4 and 14 days, it may lessen symptoms, but will not prevent disease. But the good news is, even if you give it that late, it still minimizes the pathologic manifestation of the disease. So it's important to give it. The second dose can be given up to 7 days later than the minimum 28-day interval. So you want to give it 28 days later, 4 weeks. But if you miss it and you still have 7 days after that, still give the second dose. It's very important. It does not cause lesions. Like I said, no cytopathic uptake. There are no lesions at the site of the injection. And there's no danger of auto-inoculation, transmission, or dissemination, which is always a worry, right? This is a live attenuated virus. In the past, there was that fear of this third-generation vaccine. You don't have fear of eczema vaccinatum or any of those kind of problems. And then every 2 or 10 years, if the person is continued risk, and this is very specific only for those with continued risk for exposure, then booster doses. And this is just saying why the Jynneos is the one we're using is, even though we have these two available, it is much safer in people having HIV, so immune-compromised AIDS patients or those with atopic dermatitis. So if someone has a skin condition, it's still safe to give this vaccine, because the fear always was, will it cause a widespread skin outbreak in these people? So all of these reasons, it's one of the safest vaccines to give. There really, and I'll show you another slide, but there really are very few reasons not to give this vaccine. Yeah, so this is just clinical studies. Want to show that, yeah, this is intradermal, giving it within the skin. So it's as good as sub-Q or subcutaneous intradermal routes. So it's no cytopathic or take, so there's no danger of them having any skin issues. And this is just showing you, so this is dose, 1 dose and 2 dose. And you can see in 2 dose, if you look at this study, very good confidence interval there. This bar represents all the results. And right there is the middle of that, so 86% effectiveness. Same here, if you look at 1 dose, it's still pretty effective, around the 75% range, 39% for a 2nd dose. So again, very, very effective, even with 1 dose, but you really want to do both doses. And then this is again showing you more data just to say, so that same previous slide, the real world effectiveness of a single dose at 86%. That's pretty good. This is the UK's study, and these are our US studies, which I showed in the previous. This is CDC. Eligibility in Virginia for this vaccine, I think Lauren covered this well. You had known or suspected exposure with someone with Mpox, sex partner in the 2 weeks was diagnosed with Mpox, gay, bisexual. This is very important. So GBMSM is the acronym for that, gay or bisexual men having sex with men. Unfortunately, people are like, well, is this an STI? Is this a sexually transmitted infection? But it actually is transmissible through sex. It's not a true STI because you can get it even without sexual, through sexual intercourse or sexual contact is the correct word. That is very important. I know it sounds very trivial, and this is also the reason why we're having such a hard time getting this vaccine to folks, because there's so much stigma associated with any time you bring in sexual, especially if you say gay, or that really, really makes it hard for public health to do its work. And I think it's sad because these are people who need the help of public health people like us. And we create this wall. So it's very important to recognize and not call it a sexually transmitted infection. We're seeing more of it now, and if you ask that question, why? It's simply because the sexual pattern, because once it can be transmitted by close contact, the pattern, the behavioral pattern, unfortunately is conflating it, making it appear like it says STI when in fact it is not. So yeah, important point to remember that. People will ask that, but the reality is it's not. And it's really stigmatizing when you say, it's sad. So anyway, if you have any of the following last 6 months, sex at a commercial sex venue, large commercial events, again, sex-related where Mpox transmission is occurring, sex partner with any of the risks, and if you anticipate experiencing any of these. So those are the risk factors. And again, as you can see, as I'm even going through the slide, there's a lot of social stigma and moral judgment attached to these that are absolutely unnecessary in the medical field. And our job when people come to us for help is only that. We're there to help. It has nothing to do with these things. It's not what we are here for. And it's sad because it's lost in that, and a lot of people and society in general. And then you add on that the structural inequities that are already in place, sadly over generations, doesn't help. Okay, eligibility in Virginia, I think Lauren covered this very well. Refer to VDH Healthcare Providers Vaccine Guidance webpage. I'll skip over some of these. Occupational exposure. This is very limited folks who will be needing this. Work settings, mainly lab technicians working with viruses. So it's a very limited group of people. Their occupational risks for variola virus and Mpox, I would say. And it's not recommended, this is important, as a routine vaccination for healthcare personnel. So all of us, any of us who are in the healthcare field, it's not recommended for us routinely. What we need to do is, obviously we are observing all the universal precautions, we do all the right things. It's only going to be transmitted by close contact with the lesion, with the person with the disease. So it's not that's why it's not recommended. I know it sounds, counterintuitive, if you will, but it's not. We know this for a fact. If you do all the right things, you really want to give this vaccine to the people at the highest risk. We're not at high risk. unless sexual risk factors are present, obviously. Pre-exposure, very important. So recommendation is gay, bisexual, or other same gender men who have sex with men, very important, or transgender, gender, non-binary, or gender diverse. Those are all, again, we run into the same thing. There's stigma attached to any of these gender identity folks, unfortunately. Shouldn't be the case. They're human beings. They need our help. They're applying for help. They're coming to ask us for help. That's what we're here for. And if you in the last 6 months have had it or expect to have one or more sexually transmitted infections, so there's a good reason. And weakened immune system like HIV will be a good example. Sexual or intimate contact with the person at risk for Mpox, and then anonymous sexual intimate contact with more than one sexual partner is high risk. Okay, pre-exposure, now this is post-exposure. So let's say they were exposed or at least suspect to be exposed. So no or suspected exposure. Sex partner in the last 2 weeks diagnosed with Mpox. And I just put this slide more for historical reasons. This is not what we use today, but just we've come a long way. I wanted to say, we used to use this weird device that was invented by this guy to vaccinate folks, but we don't do that anymore. We have very nice, beautiful, very fine gauge needles that we use. We don't do this. I'm so grateful I live now. All right. This is the regimen. If you're greater than 18, subcutaneous is the preferred 0.5 ml, 2 doses, 28 weeks apart, 28 days apart, sorry, 4 weeks apart. If you're less than 18-year-old person that is seeking that help, then 0.5 ml subcutaneous. The alternate regimen, if greater than 18, 0.1 ml intradermally, so that gives you 5 times the vaccine for the same vaccine, so you get 5 more people or 4 more people saved. So if anyone develops these what are called hypertrophic keloid scars, so some people had that, if they have any kind of even a fine cut, they develop a very proud scar, very hypertrophic. It looks like this heaped up little mountain skin. Those folks, if they tell you that history, you can ask them for that history as well. Make sure that you don't want to give them the intradermal. You want to make sure you give them the subcutaneous. Okay. So no required minimum interval. If someone's getting COVID vaccine and immune vaccine, so that means if they come, you can give them both. If they need the COVID vaccine and they've not had the COVID vaccine, I think it's an important thing to give. Young adults, adolescents might consider waiting for 4 weeks between vaccine. That's a very low risk, but this again, out of an abundance of caution of myocarditis and pericarditis after receipt of ACAM 2000, which we don't use, so no worry there. There's a hypothetical risk for Jynneos, which has not been borne out in the studies, but obviously it's similar, so that's why they say that. None of this, I think is a big barrier to getting this vaccine. Side effects. Okay, this is important. Pain, redness, itching. You can see with anything, pretty much any injection doesn't have to be a vaccine. Those usually fever, headache, tiredness, nausea, chills, muscle aches. Again, related to the immune response. It's not really a bad thing. And then it's safe in immunocompromised, so transplant recipients can receive it. HIV folks, atopic dermatitis. Again, this is a condition where they get the skin outbreaks that, not to worry at all. This is a 3rd generation vaccine, does not have any of those drawbacks. And these are uncommon adverse events. So kind of feeling lightheaded or fainting, 49 reports per 1 million doses. Anaphylaxis, which is a generalized allergic reaction that's only seen in 2 per 1 million doses administered. And then myocarditis and pericarditis, they're consistent with what is expected in background. So it's really, we can't tie this vaccine to the myocarditis and pericarditis. It's just whatever is the background rate we see in general population. Okay, children, this is a quick slide on pediatric. You can see on the left the pictures. That's how it looks in children. This is another reason why we need to vaccinate those at risk, because you don't want to try neonatal Mpox. You don't want that. Safety in pediatrics, 12 to 17 years of age, that so far we have received no adverse signals. 0 to 11 years of age, no clinical trials, unfortunately, for that group. And then guidance for pediatrics for persons 6 months to 17 years as pre-exposure or post-exposure if higher exposure has occurred in order to prevent this. And then children less than 6 months, then there's the passive immunity that you can give with immunoglobulin IV instead of the vaccine itself. Hopefully you don't see this and we don't see this, hopefully. Where can you get the Mpox vaccine? I think Lauren covered that. This is just the CDC's website. You can go if you're not, you're not sure, you went into your zip code and it should get you to where you can get. I'm gonna move past that as well. Whoops, this is where I want to spend some time. Okay, the next 3 slides and then hopefully I have time for questions. Okay, as you all know, it's very disproportionately affected men. 95%, and very specifically MSM, male sex with males, and of course, gay and bisexual. That's why the GB, MSM, people with that, unfortunately. And what it's done is stigmatized this. And if you remember, I don't know how many of you do, but HIV in the early days, that's how they call it, a gay disease, male disease, all kinds of weird ways of characterizing unfairly and, more importantly, dangerously, because it's causing death, suffering, morbidity among people like you and me who have come to ask us for help. And we have the magic of saving these lives through vaccines and other ways, and like Mpox, and we can't get to them because of that. So it's very important to remember that equity, racial and ethnic disparities, especially among Black and Latino and Latina folks. And then if you look at the published account that Lauren referenced, the same thing. We have to have equity-based strategies. So the messages have to be tailored because we know it's a very sensitive message. We also have to be able to reach these folks where they are, and that's much harder. And places that have done it well, they actually go down to what we call grassroots. You have to go to the place where they are, and that's much harder because it requires more effort. And sadly, we haven't put the resources behind it. Late September 22, the CDC decided to put some effort, which is laudable, but I think it's a little too late. We could have done better if we had the public health resources committed to it, which was cut back, if you remember, in the last couple of years here in this country. Strategies, this is very important, right? STI clinics, that's where you will see this population rising steadily, and sadly we're in an epidemic. We've never seen this many syphilis cases since 1950 in the United States. 80% rise in the last 5 years. Chlamydia, gonorrhea, trichomonas. I mean, these STIs, which were at one point 10 years ago well controlled, they're just taken off. I mean, it's just really sad. And I would say the easy line to draw is the reduction in funding for public health. It's very straightforward. There's no, you don't have to mince words about it. Very, very poorly, short-term budgetary reasons, very sad approach to public health. It's our world. A country is not made out of a flag. It's made out of people. You got to have healthy people to have a healthy country. You can't have a healthy country if you have disease like STIs and infections like, sexually transmitted infections rampant. And it's sadly among the ethnic and racial minorities. Again, structural reasons for that. So what are the barriers? We know it's not going to be eradicated soon. You're already, just last week we saw 3 cases not far from us. So it's there. We're not West Africa again. In the United States, we shouldn't be having these cases if we had the right public health approach. So we're behind the ball on that. We got to integrate vaccine into our routine services to prevent STI, which means we need more public health dollars for STI clinics and public health in general. Obviously, for MSM with sexual risk factors, male sex with male, vaccination is the point in time, when you can assess them for all their health needs. The problem with doing all of this is, we don't know the status. They may opt out of screening because of, current engagement in sexual hookup outside providers. These are all limitations that your clinics face. And finally, reliance on self-identification for vaccine regimen will result in greater proportion with low sexual risk. All right. So funding, staffing, designing this, how we get to those most vulnerable. And this was again in networks of sexual networks of gay, bisexual men, sex of men. So it is sexually transmissible, but it's not a sexually transmitted infection. Okay, I'll take a quick pause here. I'm going to end on just something that is unrelated. This is more to do with the impact something like a biological outbreak caused by a biological warfare type setting, which would result in lack of vaccines for Mpox. So smallpox has been used as a biological weapon, just to start there. And this vaccine we're talking about that is helping us save lives is a smallpox vaccine. So in 1943, the Mongol army were catapulting plague-infested corpses into fortified walls to get into a city in Genoa, Italy. And they won that war in 1767, the French and Indian Wars. General Amherst, the commander of Fort Pitt, used it against the American Indians. And then in 49, the last natural outbreak in the United States, and in 72 is no longer, we stopped giving this vaccine. And in 77 was the last case in Somalia that happened. In 1980, it was eradicated. And the last repositories of this for research purposes still exist. CDC in Atlanta, Georgia, and Vector, which is the State Research Center for Virology in Novosibirsk, Russia. So even a single case of smallpox will be an emergency. It immediately becomes a public health emergency in international concern. You don't need more than one. It took us a few cases before we declared Mpox in July, but this is how bad it is. So the reason I bring this up is we have an agreement worldwide with the Biological Weapons Convention, a disarmament treaty saying we should never use these, and so in 1975, and based on that categorization, and category A would be smallpox. And so if that were to happen, we would lose our ability to protect Mpox and of course then smallpox as well. So what we have left in our stockpiles, ACAM 2000, which is the replication competent live virus, the Jynneos vaccine, which we're using today, and then the Eventus pasture smallpox vaccine, which is also replication competent. So those other two are not being used because the safety profile of Jynneos is so far ahead of those two, but those two will be put into action if we ever are in that situation, hopefully not. So that's our thing, and then the resources for VEH, you can access those. I think I just put my references there as well if you want to check them out. That's it, and I'm happy to take questions.